Welcome, everyone. I'm Dr. Jessica Everett, and I am joined by Bethany Peterson. We are with Child Family Health International. And today we are convening a space to discuss health and safety pearls for global health experiences. Just a little background about me. I am a family physician. I specialize in hospital medicine and palliative care. I am in practice in Idaho, and I have my faculty appointment at UCSF as a clinical professor. Bethany, would you introduce yourself?
Yeah, of course. Hi, I'm Bethany Peterson. I don't have the accolades quite as fancy as an MD, but I came to CFHI in March of this year after spending about 5 years working in corporate America in various corporate security roles, supporting business travelers as they spent time internationally traveling on business. I also have a background working in health and safety for study abroad. That was where I first got my start out of university. So excited to be with CFHI and talk to you today about our approach to health and safety.
Thank you, Bethany. And we have Madeline Scoratino, who is our outreach coordinator and webinar extraordinaire. Welcome, Madeline. So without further ado, I wanted to just invite you all to put in the chat your location, institution, and your role. Also, any questions or themes around health and safety that you're hoping we touch on. We have content prepared, but also are ready to be flexible and have discussions. So please feel free to interrupt us with Q&A or with the chat function, but go ahead and put in the chat where are you at, your position, and anything you're hoping to learn about. And that might be a lot, but if there's one theme, I just want to make sure to meet your needs this hour. So many of you know CFHI. I have been with CFHI for 15 years, and the organization is over 30 years old. It was started by Dr. Evelyn Jones, who is at Stanford University when she was a medical student. She realized that international rotations were actually more helpful for students than they were for the host community. And she also realized that the construct of many of them felt ethically tenuous to her in terms of messaging around her going from Stanford to save places in low and middle income countries. She rotated with Dr. Edgar Rodas, who is a leader in surgery in Ecuador, and worked in his surgical outreach infrastructure. So CFHI was born out of that, and our most recent mission statement is around transformative global health rotation or education. We do have kind of a three-pronged mission. So we do research, thought leadership, as well as run programs internationally. We really emphasize local community leadership, global citizenship, and ethical engagement. Just some foundations for our approach, because I do think that the ethos of this work and the health and safety are intricately linked, and we'll talk more about that. But CFHI integrates students and trainees, undergraduate, graduate, and postgraduate into existing health systems. So we make sure to not set up any artificial infrastructure that's based on outsiders. We focus on an asset-based development framework and narrative, which is another way of saying that we really focus on the strengths of communities and individuals and groups of folks who are working towards social justice and health equity. We hold up local practitioners and community members as the experts of their own environment. In that way, I think the approach is akin to an anthropological approach in terms of how we're placing students in these environments and faculty during faculty-led experiences. We also practice fair trade learning, which is a movement out of the collaborative for community-based learning, really focusing on ensuring that host partners and communities are compensated for their time, expertise. We are a nonprofit, and the majority of the tuition goes to local communities directly. Our programs, which are designed again for undergraduate through postgraduate trainees, are located in Ghana, South Africa, Uganda, India, Philippines, Mexico, Bolivia, Ecuador, Argentina, and Costa Rica. There's a lot of numbers, but we have over 15,000 alumni. We facilitate international immersion for about 700 trainees a year currently. Prior to COVID, that number was around 900 to 1,000. We work with over 200 global partners in 35 sites. We have virtual and place-based options, and we have academic partnerships with over 100 universities. So the ways that universities collaborate with CFHI is through academic partnerships that can either be informal handshake agreements or more formal MOUs. We have received a lot of awards. We try to do best practices in terms of being a nonprofit and being transparent, as well as through our curriculum and programmatics. In terms of a breakdown of who's going abroad with CFHI annually, you can see here these shapes are proportionate to the number of trainees that are going abroad from undergraduate, mainly pre-health, but we also work with Chicano studies, with anthropology, sociology, engineering, and other majors, residents, healthcare practitioners, pre-health professionals, physician assistants, allied health students. So I mentioned earlier that I think the ethics of programs is intricately linked to the safety. And so some of the things that I think are foundational for the integrity of these programs is ensuring, number one, that your marketing and outreach and the framework for the organization has an ethical lens. Because we are talking a lot about student health and safety today, but there is also health and safety of patients and community members. In addition, the wellness of students, and Bethany's kind of going to put an underscore on this, is intricately linked to the ethical framework and how they see themselves in these spaces, what they are expecting of themselves. And so by being authentic in the way that you're outreaching and marketing to students and visiting faculty, being authentic about their role, about what they can actually achieve, is very helpful for how they do from a mental health, emotional, and wellness framework. The second foundation is really robust pre-departure training and multimodal expectation setting. So we're going to go through what pre-departure training entails for CFHI, but at the core of it is recognizing historical legacies and our contemporary biases around places that seem different, are far off, are resource deprived, and the power and privilege imbalances that exist in our global partnerships and engagement, and the power and privilege that follows students when they put themselves into a different context, particularly in previously colonized settings. And the third pillar I wanted to emphasize is the local team and host community alignment and ensuring continuous quality improvement and monitoring. So recognizing that there are competing priorities. For instance, patient safety can sometimes be a competing priority with student satisfaction. We stopped asking students if they were happy with the program several years ago because when students are going abroad, there's a disruption that occurs. And we also don't want to have local community members kind of chasing after student satisfaction. So we do want it to be a satisfying growth experience, but we want to make sure those dynamics are not one where the local team is subservient to the student. And preparing local mentors and sites for the boundaries that need to be placed on students and faculty. So what is our secret sauce? Maybe you're here to learn it and we want to give it away, and we invite you to take whatever is useful. CFHI is not just about students and trainees and faculty doing global health experiences with our organization. We really believe that rising tide rises all ships. So for whatever you can take away from this to your own institution or to other program providers and partnerships, that would be awesome. So you can see a smattering of approaches that we take. We're going to go into more detail of these, but they span things like doing health history forms and a review process, pre-designating hospitals and clinics where students and faculty will go if they get ill in country, doing multi-touch points in terms of pre-departure training, doing professional development with our global team and our in-country partners, having a strong link with our insurance and assistance providers, innovations such as telehealth options for medical care for students when they're abroad, ensuring formal leadership roles and responsibilities for local team members, having structured and unstructured debriefs and um, multiple ways that partners and local team members communicate that try to honor cultural preferences, to paying attention to dietary modifications and allergens and being able to accommodate students who are kosher or who need halal meat or who are vegetarian or who have celiac or who have, anaphylactic reactions to bee stings or other things. So there's a lot of different pieces to this. Some of them are on these slides, and we'll go into detail on some of them. But if there are topics here that we don't go into detail on that you want to discuss, we're going to have Q&A and discussion at the end, and feel free to put questions and answers into the chat or Q&A function. I wanted to mention that, there is health and safety concerns of international education, any type of education abroad program. But there are also unique and health and safety concerns for health-related programming, whether that happens in public health settings or in clinical settings or a hybrid of the two. Some of the unique settings, and many of you are in medical education, so you are dealing with this in your home institutions as well, include the physical risks of clinical and healthcare environments for the student, body fluid, blood exposures, needle sticks, other exposures, the physical risks of clinical and healthcare environments for patients. So, we know that there is a legacy in global health, international medicine, and tropical medicine of allowing outsiders to do more than they have expertise to do. So, the risk to patients is not insignificant. That includes things like diagnostics, therapeutics, language, procedural safety, etc. There's also significant psychological risks for students, even students or trainees who are residents or medical students, or those of us who are faculty. When we go to an environment where people are dying, children are dying, adults are dying from diseases and social determinants of health that usually are not life-threatening in our home environment, there is a psychological strain. The burden of disease is different, the resource level is different, the culture is different. And so there's a significant psychological toll. And many of us in medicine have been a culture to try and be very strong and resilient, and many of us are. But I think increasingly we're recognizing the need for wellness and for opportunities for self-care and for recognizing the psychological toll that is inherent to healthcare settings. And then legal risk for students. So, you have highly professionalized environments that require licensure and professional competency that are context linked. This is a concept that was recently published in terms of context linked and context free competencies. So some of our competencies as clinicians, doesn't matter where we are, we can be competent in that. It's not contextualized, versus many of our competencies for care, both diagnostics, taking histories, treating, understanding context of illness, are context linked. And so even if, I'm an expert in Idaho or in California, I pick myself up and go to Ghana, Uganda, India, my expertise does not hold up. And so realizing that there's real legal risks for me and for our trainees when we're in new settings. Bethany, Madeline, and I are representing a huge international team that is not here today. They are busy facilitating trainee experiences in their communities. But I wanted to name that we have the privilege of representing our team today, and they're really, in many ways, doing the hard work. And so we're grateful to be able to represent that work and represent our whole CFHI global team. I mentioned pre-departure training. So there's many approaches to pre-departure training. Some of it is more curricular content focused on global health content. Some of it is more culturally focused. CFHI tries to take a 360 perspective on this. So our pre-departure training is both asynchronous, so online modular based, as well as synchronous in terms of live virtual orientations and then on-site orientations. The asynchronous content includes a program overview module. So that is specific to the country, community that the student's going to, the cultural norms of that location, includes things, logistics like packing lists, like where you're going to meet people at the airport, food considerations, things that are very specific to that location. And then there is a self-care and wellness module, which Bethany can discuss in more depth. There's a global health ethics module, which includes the Global Ambassadors for Patient Safety resource that's out of University of Minnesota. This is an open access resource, so anyone can use it. It is focused more on undergraduate pre-health students, but I think the concept of being a global ambassador for patient safety is relevant for medical students, residents, faculty, as well as for pre-health students. So while the module, the language, some of it is geared towards pre-health and undergraduate students, it still is a relevant construct for all of us. And then we have the Pillars of Global Health, which is a curriculum that universities can actually use independent of CFHI programs, but we use it for all of our scholars. This includes some of that global health specific content that I mentioned. So global health definitions and discourses, which talks about kind of the historical legacies of global health, discourses and debates in the current day of global health and international medicine. Planetary and One Health. So we also have a planetary health pledge that our scholars all sign that elevates the awareness of how their going experience abroad and travel actually has environmental and planetary impacts. And then recognizing a broad notion of health in terms of the intersections of human health, environmental health, animal health, and ecological health. And then there's a module on global health ethics, social determinants of health, diversity, equity, and health disparities, cross-cultural effectiveness and adaptability. I'm going to talk a little bit more about this later in the hour, but we utilize two validated instruments, the Intercultural Effectiveness Survey, which is out of the COSI group, and GlobeSmart, which is out of Aperion, as tools to training cross-cultural fluency. Pillars of Global Health also includes global burden of disease and health systems. We also have a participation agreement, which outlines commitments that participants are making in terms of behavior, rules, regulations, and processes. I mentioned the Planetary Health Pledge. We also have a video, photo, social media policy, which really asks trainees to pause and really think about what they're taking photos of, ensuring that they are not taking photos in clinical settings, that they are asking for permission and recognizing that culturally many people will not say no. And just thinking about how we are portraying others. Are we portraying them at their best moment or their worst moment? And what narrative are we reinforcing? Similar to like if you took a picture of me now versus when I first wake up in the morning, you would probably get a different sense of how I am in the world. And so that applies to all of our community members. And it's very easy to take images that reinforce a narrative of deprivation and pity in resource deprived settings. So we really want trainees to question what we're putting on Facebook and Instagram. No one uses Facebook that's going on our programs. I'm old, but Instagram and other social media platforms. And then we do health history forms, which are basically collecting information about pre-existing illnesses, timelines of those, recent hospitalizations, medications that will be taken abroad. And then we have a process that Bethany and I will talk about more to reviewing those and ensuring that students are bringing their medication supplies in the right way. If they're on controlled substances, we have an advising process for that, and ensuring that we have a sense of accommodations that they need for pre-existing health mental health conditions. So I'll turn it over to Bethany to speak to resilience and some other aspects of our work.
Yeah, thanks, Jess. So I'm going to jump first into our pre-departure process. A lot of the things that Jess just outlined, both the asynchronous and the synchronous pieces of our pre-departure process, and we try to approach that with a lens of resilience. So, Jess, if you want to go into the next slide, I can talk about why that is. and what we're looking to build in students during the pre-departure process. So we define resilience as the capacity to withstand and recover quickly from difficulties. And just thinking about this personally, I think this applies both in the psychological sense and in the physical safety sense. The more that we're able to quickly adapt to things obviously plays a role in our physical safety while we're abroad, our ability to have situational awareness, and also is going to help you to bounce back quickly from those cultural challenges that Jess alluded to before that can eventually spiral and become a much bigger mental health concern. Um, so really what we're trying to build in students as much as we can before we get to the program is that increased intercultural adaptability, really frank discussion and understanding of what those realities are that they're going to face on their program, and build some self-awareness in them on how they're going to be perceived locally. I won't go into too much detail because there's lots of data out there about the prevalence of mental illness among college age students. And really, this is an important conversation to have with anyone because culture shock can happen to any student, regardless of whether they have pre existing conditions or where they're going, et cetera. So, building resilience is something we focus on with every single student. And of course, as just mentioned, we have our health history review process where we identify students who have pre-existing conditions and make sure that we're meeting them where they are. But this is something we like to build with everybody. And of course, as Jess alluded to earlier, every student can encounter, for example, traumatic situations in a medical setting or cultural misunderstandings that, as I mentioned before, can kind of spiral and become a more difficult situation. And additionally, the realities of engaging ethically in global health. I won't go into too much detail because I think Jess covered that really well earlier. But recognizing those complexities and dealing with the fact that they are a learner in their environment rather than a change agent can create a sense of lack of agency at times. So we try to teach them how to manage those feelings and the realities that they're going to face locally on the program. Another reason why we talk about this is because it connects really directly with the learning objectives that we have for the program. And we like to show this slide quite often. It's in our pre-departure orientation as well. But this is a study that came out of USAID contractors showing perceived weaknesses of domestic health professionals moving into the global health sphere. One of the things, you'll see the second thing there on the graph, is flexibility, adaptability, and creativity. They're not necessarily looking for clinical skills. They're not looking for those hard skills that students might first think of. They're looking for students to have more flexibility, more resilience, as we like to focus on. So I think, as Jess mentioned before, it's not only important ethically, it's not only important for their health and safety, but it connects really directly to the things that are going to be beneficial for them professionally down the line as well. So when we take a step back and think about how to build our pre-departure process, it's important to focus on what CFHI has control over. Of course, students are going to come to us with their own pre-existing conditions. They're going to come to us with certain aspects of their identity that play a role in their program that we don't necessarily have control over. But what we can do and what we try to focus on overall in our pre-departure process is talking about mental health, talking about cultural flexibility early and often in order to normalize these conversations, in order to make it very clear and transparent with students that they are going to have experiences that are going to challenge them, that are going to test their mental health and their flexibility, and make it very obvious that it's important to build those skills before they get to their program site. We can also set goals with them and highlight shared values, which is why we talk so much about the ethical pieces of the program, our approach to global health, in order to make sure that students are on board with that and understand that what CFHI is trying to do in the field of global health in order to make this a more equitable space for everyone. So if they do later on down the line experience something that they find confronting or difficult, we can harken back to, okay, how can we ensure that you complete your program successfully or meet the goals that you have personally, as well as the goals that we've set as a group, and kind of give that motivation to the student in order to persevere and be more resilient. We also focus a lot on, sorry, Jessica. Yeah, we also focus a lot on enabling healthy group dynamics. So we have lots of conversations, which I'll go into detail later with our local teams, lots of ongoing professional development on how to make sure that we encourage students to support both themselves and each other on programs, and don't leave, for example, a student isolated on a program, which we know can be a red flag for mental health. We also talk with them early and often about planning for their own self care and ongoing treatment if they need it. They also have access not only to the follow up that myself and Jess might do based on their health form, but also an alumni advisor is going to be reaching out to them during their program, before and during, on a regular basis, to just provide some peer mentorship and another ear to listen and ask questions of, if they find that they need it. And of course, as I mentioned with the staff training, we also talk about risk factors and red flags so that we can keep a really close eye on students and recognize when they're struggling early, and intervene sooner. So talking a little bit more about some of the modules that we have before students arrive to their program. Jess mentioned earlier our mental health and self-care module. There's an image here on the right with just one thing that is included in that module and one tool that we use to try to give students some more frameworks for resilience if they don't have them before they get there, which is the 5 4 3 2 1 grounding exercise for managing anxiety. Just an example, but it is about a 20-minute module that will provide them with some more tools and conversations in order to think frankly, reflect on their own mental health and how they're going to take care of themselves on their program. We're also in the process of developing an identity and safety module, which would be added to our pre departure process, which encourages them to reflect on both the visible and invisible aspects of their identity, how those might play into their experience on the program, and also provides some resources for certain minoritized communities that might need additional support. And I'll go into more depth about that later. We also encourage students throughout the process to recognize their own role in their health and safety. Of course, CFHI plays a role, their home university might play a role, but students really are the ones on the front lines, making sure that they don't find themselves in a difficult and sticky situation. So helping them to recognize that they have a role in letting us know when they need support and making sure that they're not putting themselves in a dangerous situation is another thing that I think can often be overlooked, but is incredibly important. Um, I won't go into much more depth about the health history form review. Based on the information provided on that, I reviewed the initial forms that we receive and collaborate with Jess in order to make sure that we are continuing a student's treatment plan as needed and providing them the individualized support based on their particular situation, in order to ensure that we have an equitable program that they can participate in. We talked to them about reflection models, which I'll go into more depth on later. And as I mentioned before, that peer mentorship is available to them at any time, and is available early in the process as well. This slide comes directly from our pre-departure orientation, and it's one of my favorites. So I wanted to spend a couple moments talking about this one. I think the first bullet in particular is really salient for me. We talked to them very early about shifting some of the assumptions that they might have coming into their program and shifting from that sense of certainty to a sense of curiosity. I think when you think realistically about the encountering a difficult situation, encountering a misunderstanding while you're on your program, having an approach of curiosity, asking questions, understanding why, and being a learner in that situation is, I think, directly correlates to our goal of building resilience with students and creating a situation where they are seeing every opportunity as a way to learn, a way to move forward, and won't necessarily be stuck in a place where they're unable to adapt to the new reality that they might be facing. So there are several things here that we kind of encourage them to change their framework and approach the situation in a way that's going to be more productive and enable them to learn and grow in their new environment. But I think this really, this slide in particular sends that home for me personally.
I'll just add to that, Bethany. I think when it comes to health and healthcare and low resource settings, it is very common for students and those of us that come from a high income or resource kind of flush environment to go to a place of criticism, to think, to see problems. I mean, psychologically, it's very normal for our brains to do that. There's also a psychological concept called the oversimplification cause fallacy. And what that means is that our brain will try and explain complex situations in very simplified ways. And unfortunately, that oversimplification doesn't serve students' learning, their professional or their personal development. And so we truly try to emphasize that expansiveness and trying to grapple with complexity. And then there's those pressures that students often feel when they go to low resource environments that they need to fix, help, save. And some of that is very well intended, some of that is colonialism and is racism and is unconscious bias creeping up. And really, before we even appreciate reality, we're making assumptions about what people need or how they should do things. So, CFHI's tagline, "Let the world change you." And I know many of you on this webinar are trying to do similar things where we really try to get learners in a mental place to learn constructively and to take it all in a way that is going to help them grow and not help them and not kind of encourage them to play on biases or to go to a place of exceptionalism or to oversimplify. So by naming these in pre-departure training, I think it helps. But obviously, one contact point isn't enough. So part of what we're doing is trying to have this be over the life cycle of their in-country experience and then post-experience part of the ethos of the community.
Thanks, Jess. So this slide in particular is one that we have on our pre-departure orientation, which is a virtual synchronous session that we have with students. But just to speak briefly on this, we encourage students during the session while we have them there live to think about what they do currently in their home situation to take care of themselves. What is their current routine? And is that realistic to bring with them onto their program? Is running going to be a good option, for example, in La Paz, Bolivia, with the altitude to consider? So we talk to them about the importance of reflecting on what they do currently and making sure that those are realistic things that they can bring with them to their program. And if not, what their plan is to do if they do need a routine in order to regulate, and what they might do if they find themselves struggling. So, how they can reach out to support systems, use the coping mechanisms that I mentioned before in the asynchronous module that we have in order to recognize when they need support and be able to regulate themselves while they're on their program. During that orientation, we also have a slide talking about identity, and depending on the size of the group, we might send them into breakout rooms to talk about an aspect of their identity, whether it be visible or invisible, and how that might impact the way that they're perceived locally while they're abroad, and if that perception may have a role in their own health and safety while they're abroad. And it's very interesting the different conversations that come up, but I think this is a really effective way to approach the conversation because it allows students to really recognize in themselves what is the aspect of their identity that is the most salient for them, which one is most important to them, and might be the biggest point of contention or confrontation if it does come up while they're abroad. So really leads to some very great conversations, and encourages students to reflect on some of the realities that they might face before they get there. So as I mentioned before, we're also building a module specifically about identity and safety while students are abroad. Um, and that is also in collaboration with SASE, a health and safety consultation service that we partner with very closely. But we really encourage students to focus on the connection between their identity and their experience abroad, reflect very deeply, as I mentioned before, on how they're going to be perceived abroad. There are a series of questions and reflections that we encourage students to take some time to fill out. And it also has specific information for certain identities. For example, LGBTQ considerations. We ask students how their gender might be perceived abroad, how they can be an ally to other people on the program, even if they don't identify with a certain aspect of identity. So, really encourage every student, as I mentioned before, to reflect on these things as they're relevant to each of them. Another thing we focus on before departure is introducing students to reflection modules, which is used very frequently during their time on site as well to unpack some of the difficult experiences that they might face or those confrontational things that they might witness, for example, in a clinical setting. So this is just one model. I know that Jess is very familiar and supportive of this module, but it's very simple. What, now what happened to you? What was the situation that occurred? So what, why was this particularly impactful for you? Why did it catch your attention? Why is it something that you found confronting? And now what being the actionable piece? What are we going to do moving forward? How are you going to incorporate that into your work, into your professional career? Or how are you going to interpret that situation in order to move forward from it? And just speaking briefly to how the on-site experience kind of connects directly to what we're talking with students about pre-departure, we encourage them to journal regularly as a reflective exercise and find that this, again, helps to build their resilience. The more that they're reflecting and unpacking their experiences, the more they're approaching things with curiosity. We try to focus very much on establishing trust with students. Our local teams have lots and lots of years of experience working with CFHI students. And again, building trust and building those strong group dynamics that enable a flourishing program. We also, again, try to focus on recognizing red flags as soon as possible. For example, if a student begins to isolate and separate from the group, recognizing that early as a sign that they may be struggling and intervening sooner has allowed us to, avoid more difficult conversations down the road. And those weekly check-ins with alumni advisors as well, they have lots and lots of resources that they can reach out to, and based on who they're comfortable speaking with.
I wanted to speak to kind of the intersections of cultural fluency, preparation and training, and wellness, safety, and health while abroad. So, as I mentioned, CFHI uses two tools in our pre-departure training. Our global team has access to these tools, and so we use it as a way to debrief, to understand each other, working relationships, to strengthen our partnerships as well. So it's used in a multidimensional way. But the IES is called the Intercultural Effectiveness Scale. Basically, it has three kind of main domains and six subdomains. And what it does is it tries to measure students' kind of innate and socialized predisposition towards cross-cultural effectiveness and exploration. So under the continuous learning domain is self-awareness and exploration. Under the interpersonal engagement is world orientation and relationship development. And under hardiness is positive regard and emotional resilience. They take this pre-departure and they get about a 35-page report that talks about their strengths and their opportunities and what areas they can improve upon, and some mechanisms to do that. And then we also partner with Aparian Global, which is a cross-cultural effectiveness trainer for like Fortune 500 companies. They have what's called the Globe Smart tool. And what they do is the trainees take a self-assessment, or the team members take a self-assessment, and it plots them along five kind of cultural continuums. So are they more independent or interdependent, egalitarian versus status oriented, risk versus certainty oriented, or uncertainty avoidant, direct versus indirect, which applies to communication, but also nonverbal communication, and then task versus relationship oriented. And then they can compare themselves to 102 different countries, including the countries that their program is in. They can also compare themselves to other students. And then there's in-depth advice for how to be more cross-culturally fluent. So this is a helpful, I think, starting point. But I also think that we have to recognize the connection between cultural incongruence and emotional response. And so I used to use the iceberg model of culture. I'm sure many of you have used some of these analogies. What I'm using more frequently is the tree model of culture. Is anyone else, has anyone seen this or used this as a curricular element? I'm just wondering if anyone could share, or are there other models that you're using that you find useful? Does anyone want to unmute and share with us um, their experience? Or put it in the chat function. I'm just interested in anyone, if anyone is having similar results with using the tree model or the iceberg model or another framework. The tree model, the reason I like it is because it does call out the impact on trust and on emotions that cultural alignment or disalignment has. So the way that this model works is that there's surface culture, which are observable patterns. So things like the way people dress, songs they listen to, dance they do, holidays they celebrate. These are observable patterns, things you can take photos of, things that you can take part in. Generally, people can be different in this way. So you could dress differently, we could eat different food. But that's not going to necessarily impact my sense of trust of you or sense of ability to work with you, or it's not going to go to the core of my tendency to judge or to come to conclusions about you. Then you start to get into shallow culture, which are unspoken rules. So these include like concepts around time, the tempo of working, the nature of relationships, concepts around what honesty is and what being honest means or how that manifests, eye contact, sense of personal space, um, nonverbal communication, child rearing practices. When shallow culture is different is when we start to potentially go into distrusting someone or feeling like, or jumping to conclusions or judgments, such as, okay, concepts of time are different. So you arrive to a meeting, 5 minutes before it starts. I infamously come 10 minutes late to everything. And then you make the judgment that I am lazy or that I don't think you're important enough to come on time. Rather than recognizing a cultural incongruence, you start to have an emotional impact on the sense of trust and the sense of alignment you have with another person. Then you get into deep culture, which is collective and unconscious. And these are things like sense around spirituality, cosmology, notions of fairness, decision making. So, those of you that are clinicians, you know that when a family or patient has a different decision making structure, when it's not individualized, but more interdependent or collective, it can really challenge healthcare providers and team members who are used to individualization and autonomy as being prioritized. So, deep culture can have an intense emotional impact on trust. So, when concepts of self, worldview, decision making, notions of fairness are different, it can be very unsettling. And it can lead us to judgment about another person or a group of people, but also distrusting those individuals or those communities. And so utilizing the tree analogy, I think, helps to call out that there may be a response. And this links to success that students and trainees have in global health experiences because as you encounter cultural incongruence, if you go to a place of negative regard, which is how the IES puts it, basically when someone is different than you, Do you go to a sense of curiosity or do you go to a sense of judgment? Do you go to a place of positivity, growth mindset, enthusiasm for the difference, or do you go to a place of negative regard, judgment, labeling, stereotyping, or otherwise distancing oneself? And so, if students are going to a negative regard, then that can lead to an emotional response that's negative, which then can lead to a behavioral response, which is negative. And then ultimately, that can undermine their success in cross cultural settings, but also their entire experience during a global health immersion, whether that's a rotation, a practicum, or an internship. So, by setting up the understanding that things like eye contact, sense of time, senses of what it means to be honest, definitions of kinship, how we identify as groups or as individuals, by setting that up as being going to be different, and that there is going to potentially be an emotional response, and that it can either be positive or negative, it helps, I think, students have a framework for when they get into those situations. They potentially are not having the tendency of going to negative regard, but actually developing their ability to have positive regard.
All right. In the interest of time, I'll speed through some of these slides. I want to talk about some of the logistics of how we manage incidents on site for those who are curious from a health and safety standpoint. So, Jess, if you want to go to the next slide, our support structure for students on site, as I mentioned before, is really robust. They have access, of course, to our on site staff, which will include our local coordinator as well as the on site medical director, who are available 24/7 if a student needs anything. We also have a 24/7 emergency line, which comes straight through to me. And really, any member of our central leadership team is available to support and respond to a student in the event they need support with really anything before or during their program. We work with a 3-tier incident tiering framework. I would say that 95+% of the incidents that we manage with students on site fall under our tier 1 category, which is really just either a group or individual incident that occurs with minimal disruption and may or may not require immediate response in order to resolve. That would include, your mild illnesses, your GI issues that happens to every student everywhere, no matter where they're going around the world. Then moving up from there, our tier 2 incidents are either individual or group incidents that are considered urgent but not an immediate life safety issue. They interrupt normal participation in the program and require action to resolve. And then tier 3, I think we're all familiar when those alarm bells start ringing, are those immediate life safety concerns that require an immediate response as well. So we in our health and safety work, we partner with several different professional groups as well as intelligence providers. We partner very closely with OSAC. Recently attended and supported with an OSAC event here in Oaxaca, Mexico. And I am a member of Pulse, which is a group of professionals working specifically in health and safety for education abroad. And we also partner very closely with our intelligence provider, which is available through our student insurance plan that I'll cover later. But we have really a robust network of people that we can call on for intelligence, as well as benchmarking and any other support as we manage incidents with our students. Our general process, speaking in broad terms, when a student reports an incident, is that the local team is there to respond immediately and assist them in whatever is needed, whether that be facilitating healthcare, accompanying them to that healthcare facility, assessing their emotional well being, making sure that we're taking care of their immediate needs as they come up. And then the local team will then loop me in as soon as possible after they attend to those immediate needs. And I will conduct the follow up, which may include reaching out to the home university for the student, providing the student with insurance information, convening our crisis management team if it is a more involved or emergent situation, as well as our assistance provider. Of course, we're constantly evaluating students' emotional well being. So if we need to offer support and counseling, we'll do that and facilitate any other necessary follow up based on the nature of the incident. So Jess alluded to this earlier, but I want to talk about some CFHI specific considerations, given that we are a global health organization, and call out the fact that while many of our local team members are trained and licensed professionals in the country that they work in, our staff do not provide care directly to participants. So our local medical director is there to help develop emergency plans, to support students, to take them to visits with other providers, but they don't provide care directly to students. I will say that they are uniquely qualified to develop strong relationships with our trusted care facilities, and know really the best places to take students based on their locality, in order to ensure that they receive the highest level of care. And our global medical director, who's here with us today, Jess Everett, can help us provide context as well to those physical health incidents that might occur and supports with health history review as well.
I'll just add one thing, when we do site visits, we do go to the health facilities that have been designated as the primary places where students or trainees or faculty will be taken if they get ill. This is very helpful because oftentimes there are forms that need to be filled out for insurance, or there are other ways in which a direct relationship really helps with those facilities. We recently had a situation where we needed insurance forms filled out and a fit to fly form, which is basically when a student is ill and they need to be medically evacuated, they have to have a doctor sign that they're fit to fly, quote unquote. And we had the health facility wanting to charge for that. We had then at the same time, they refused to fill out some of the forms and were uncomfortable with it. So one pearl for everyone here is that it's really helped to build relationships and let those facilities know to expect these forms, that the insurance expects doctors to fill them out. It's not always culturally the same in terms of filling out forms like we're used to doing in a US context. So just to highlight that when you're doing site visits, it would be very helpful to identify these institutions and to set expectations around what type of formal things they'll need to do for the US-based institutions involved. In addition, setting up payment contracts. So one thing we found with the insurance providers, the ISOSs of the world and other assistance organizations that many universities have, is that their networks in low and middle income countries, such as the ones that we work in, are not built out as much as they are as in like Europe or other high income countries. And so we have had to kind of vet institutions locally, in addition to the assistance companies' help. So just a flag that if you're working in low middle income country environments, it's very helpful to be doing that when you're doing site visits or making sure that people you're contracting with are thinking through that.
Well put. I think we can go to the next slide. So Jess already alluded to this earlier as well, but I want to call out some of the specific risks that are present for students working in a global health context, and why we inform preceptors of participants' skill levels so clearly during the pre-departure process is in order to avoid those situations in which students practice outside of the scope of what they are legally allowed to do in a country. Of course, liability is a huge concern, and we don't want to find a student coming into some kind of issue with the law, which is why, again, we inform them about the limitations of practice and the ethics of the programs. Participants are also informed about standard precautions, which I know is pretty obvious and relevant to everybody after living through the pandemic, but we like to remind them about protective gear, covering their cough, and courses of action in case of exposure to bloodborne pathogens, sharps, etc. So we talk with them about that during our virtual orientation as well. And we do have a strong focus on avoiding placement of students in clinics that might be high risk for certain situations such as COVID, TB, and bloodborne pathogens. So we do keep that in mind as we look for placements for students in rotations. All of our students are enrolled in an insurance plan. I'm sure everybody, if you're coming from a university, are familiar with having student insurance for education abroad programs. Our insurance is provided through Zurich, who partner with On Call for our travel assistance services. As just mentioned, the networks in lower and middle income countries can be tenuous for direct billing agreements with insurance companies. So we've found that in order to provide the highest level of care for students, we typically go for a reimbursement process. So we refer them to our trusted medical facility based on our medical director's suggestions and work with students in order to pay out of pocket and ensure that they are reimbursed for most routine care. For something more involved, we will work directly with the insurance company to set up a guarantee of payment and get that arranged so that a student doesn't have to pay a heftier bill themselves. There are also telehealth services available for physical health consultations, so that is available to most of our students as well, should they prefer a virtual option. Of course, CFHI has a zero tolerance policy for harassment of any kind. And just to speak very high level about our process, if anything is reported to us, specifically if it's reported within the context of their clinical setting, we have a really close partnership, as I mentioned, with all of the clinics and NGOs, et cetera, that we might send students to for rotation. And our process is to partner very closely with obviously the home institution for that student, follow your institution's Title IX policies, but also follow the HR and inappropriate conduct policies of the clinic or the setting in which that may have occurred. We have long-standing partnerships with those clinic sites, and they take those situations very, very seriously. So our medical director will partner with them closely to conduct an investigation per their internal processes. And in the meantime, we'll take any interim action to ensure that that student, as well as any current or future CFHI students, are safe while that investigation is being conducted. For custom programs, just to speak really briefly, because I'm sure many of you here on the call are faculty and maybe looking to lead students on a program with CFHI or a global health program in general. Our approach is very collaborative at CFHI. We like to have planning meetings for every outgoing group, as well as facilitated feedback and reflection sessions upon return with whether that be advisors from your university or the faculty yourselves. And we focus on building an intentional approach and ensuring alignment in our learning objectives for custom programs. There's an active communication line open at all times. We found that WhatsApp groups are really effective. So we typically, if there's faculty on site with students, we'll create a group that will allow you to communicate with myself as well as the local staff immediately if you need support with anything. And we also require all faculty who are going to be on the ground with students to complete a training module, which really covers what our expectation is of your role as a leader on site with the students and how that interacts with our local staff and how to manage incidents when they do come up. All right, I think we're running very short on time, so I might skip our example of an incident response, if that's okay with you, Jess.
Sure. I mean, I'll just mention that there was an attempted coup in Bolivia recently, and there was a kind of swift response, and Bethany did an amazing leadership job alongside our local partners and staying in close contact with the State Department. One thing I'll mention is on campus, you have a lot of resources that may be helping with various aspects of this work. So happy to speak to how those collaborations happen. Our local team professional development, I just want to give some examples because oftentimes we talk about our partners in country and it's kind of this vague term. And generally medical schools and universities have both direct partnerships based on faculty relationships often, and then also relationships with organizations like CFHI to meet demand of students and diversity of locations. We have increasingly provided professional development to our local teams and partners, including how to support diverse identities. We debrief case studies and incidents, teaching how to facilitate reflection and critical reflection. going through those insurance forms and processes for the insurance. We've recently had an increase in parents wanting to be involved on site and even going with their students during international experiences. And so we've developed a process around that that got buy-in from our global team. And then also mental health conditions and responses, which are often culturally contextualized. So important to think about that cultural aspect. And then the advising and support we've kind of talked through. For those of you that can stay on, what questions do you have? So Tamiko, yes, we will share the slides and the recording. Um, and the modules you mentioned. So Tracy asked about the modules. So if they're available open access or not. Some of the content we have is open access and some of it is not. So the pillars of global health is because we have to pay a fee to the infrastructure. There is a per student cost for institutions for that. Other resources are open access and happy to share those. Any other questions or comments? Just looking here. Okay, I know everyone has a busy schedule, so you're going to be signing off, but please use our emails. I put them in the chat and be in touch if you want to learn more. We're here to be a resource. And thanks for taking time today.
Tracy has a question about what LMIC stands for. That would be a lower or middle
Oh,
income
low middle
country.
income country, sorry.